Assalamu alaikum wa rahmatullahi wa barakatuh. I'm happy to be with you today in the annual Saudi Hematology Congress. This is the last day, and I hope that we will all benefit from all of the important information that we will get today. It is my great honor to introduce our two moderators for session 1 and session 2. For session 1, it's Dr. Murtada Ghabouri. He's an associate professor and senior consultant hematologist at Sultan Qaboos University Hospital in Oman. His area of interest are malignant stem cell disorders, acute leukemia, and bone marrow transplantation. The second moderator is Dr. Hazzaz Zahrani. He's a consultant and head of hematology and stem cell transplant at King Faisal Specialist Hospital in Riyadh. So from here I will hand my microphone, and thank you very much.
Thank you, Dr. Mohammadi, for the introduction. And I would also like to thank Dr. Marwan, Dr. Firas, and the other organizers for the invitation. Today is day 7. It is about benign hematology and transfusion medicine. In this session, we will have 3 talks. It is my pleasure to introduce the speakers here. Each talk would be about 25 minutes. We would love to have questions. We would love to have interactions. As they come, please, as participants, put them in the Q&A, and we will discuss them at the end, inshallah. It is my pleasure to introduce Dr. Thomas Ortel. Dr. Thomas Ortel is the chief of the Division of Hematology at Duke University Medical Center. He's a professor of medicine and pathology, and he's the director of the lab-based research for the Department of Medicine. He also serves as a director of the Duke Hemostasis and Thrombosis Center, director of the Duke Anticoagulation Clinic, and the medical director of the Clinical Coagulation and the Platelet Antibody Laboratories at Duke. He would talk to us for the next 25 minutes on the new indications for the DOACs. Dr. Ortel, the mic is yours.
I'd like to thank the organizers for inviting me to talk here today on the new uses for the direct oral anticoagulants. My name is Tom Ortel. I'm from Duke University in North Carolina in the United States. The direct oral anticoagulants are a class of agents that target a specific clotting factor, and there's 4 anti-factor Xa agents approved in the US, 1 antithrombin agent. Currently available in the US are only 3 of the anti-factor Xa agents. These drugs have now been around for over 10 years and have been finding an increasing number of uses. These are the currently approved indications and approved drugs in use in the United States. All of them have been approved for atrial fibrillation stroke prevention. All of them have been approved for treatment of VTE. 3 of them have been approved for extended treatment periods of venous thromboembolism, and 3 of them have been approved for orthopedic procedures. Now, there's also a number of off-label uses that these drugs are employed in, including, for example, with rivaroxaban, acute coronary syndromes after stabilization with initial management, HIT, acute symptomatic superficial venous thrombophlebitis, and venous thromboembolism prophylaxis after a non-major orthopedic procedure. Apixaban is also used in HIT and prevention of recurrent stroke and TIA in patients with MI. But what about new uses? What's coming along? What are people looking for? So we're always looking for treatments for venous thrombosis in unusual locations. And let's start with cerebral venous thrombosis. Here, there has been published a couple of years ago an exploratory prospective randomized parallel group open label multi-center clinical trial that looked at dabigatran etexolate in patients with cerebral venous thrombosis. And the trial design is shown here. There was a screening and diagnosis period, after which the patient received a parenteral anticoagulant for 5 to 15 days, and then were randomized to either dabigatran or warfarin for 6 months with follow-up 7 days afterwards. And what this trial showed, trial was known as RESPECT CVT, was that for the primary outcome, which was the combination of major bleeding or venous thrombotic event of any kind, dabigatran etexolate and warfarin were essentially equivalent. Secondary outcomes similarly, as well as secondary safety outcomes, there was no evidence for increased bleeding. And this allowed the authors to conclude that patients who had cerebral venous thrombosis could be anticoagulated with either dabigatran or warfarin, and they had a low risk of recurrent venous thromboembolism and a risk of bleeding that was similar with both medications, indicating that dabigatran at least could be used in patients with cerebral venous thrombosis. What about splanchnic vein thrombosis? This is another area that we see a lot of patients with, and can we use these drugs there? This was a paper that was published last year. It was a retrospective review of over 300 patients with non-cirrhotic portal vein thrombosis over almost a 20-year period. The primary outcome here was not clinical symptoms or clinical evidence, but it was a radiographic imaging improvement of the portal vein thrombosis established on follow-up imaging. And what the authors were able to show was, on this slide, you can see this dark blue line here. This is any direct oral anticoagulant. Enoxaparin is in green, and this is showing the probability of resolution of the portal vein thrombosis. You can see that the DOACs as a class were as good as enoxaparin, both of which were better than warfarin, which was in the purple line. And obviously the red line shows that you do get some low rate of spontaneous resolution, but it's very low, indicating here that the DOACs looked as good as the low molecular weight heparin, which is the drug that we use most commonly. And what about cirrhotic portal vein or cirrhotic splanchnic vein thrombosis? There have been several studies that have been published, all of which are small or retrospective, but they have looked at the antithrombotic treatment with direct oral anticoagulants in patients with splanchnic vein thrombosis and cirrhosis, the DOACs in chronic portal vein thrombosis in patients with hepatic cirrhosis, and there was even a small controlled trial of rivaroxaban versus warfarin in the management of acute non-neoplastic portal vein thrombosis. All of these small studies suggest that this drug will be useful in this patient population with cirrhotic splanchnic vein thrombosis, but none of them are really strong definitive data, but they are suggesting that appropriately a trial should be done. But in the meantime, these drugs are options that could be used. Now, the interesting thing also about this is that as these began being used in patients with cirrhotic splanchnic vein thrombosis, the question became, well, what would you do if you wanted to list this person for transplantation? And with the development of the reversal agent for dabigatran, idarucizumab, there have appeared several small case reports of patients who had an indication for an anticoagulant being maintained on dabigatran, and then when they needed to have their liver transplant, the dabigatran would be reversed with idarucizumab, allowing then kind of a safer option for how do you perioperatively or peritransplant manage anticoagulant therapy in these folks with portal vein thrombosis. This soon then became applied in patients with cardiac transplant surgery as well as lung transplant surgery. And most people are leaning towards using the combination of dabigatran and idarucizumab. There is some concern that if you use an anti-10A agent and try to reverse it with andexanet, you might have thrombosis. This is something that's hypothetical and needs to be studied further, but this does give an option for the transplant patient population. Now, what about cancer-associated thrombosis? Okay, there's been a lot of data in the last few years on cancer-associated thrombosis. There's 4 prospective randomized trials that have looked at it. The first one that appeared was the Hokusai VTE cancer study. This was an open-label, non-inferiority design trial that studied adult patients with objectively confirmed cancer who had either symptomatic DVT or PE or an incidentally identified DVT or PE, and incidentally identified PE had to be at least segmental. They were treated with a low molecular weight heparin for at least 5 days, and then randomized to either edoxaban or dalteparin, with a primary outcome being a composite endpoint of recurrent clots or major bleeding. And what they were able to show was that if you looked at either dalteparin or edoxaban for that composite outcome endpoint, the outcomes were similar. There was no difference between dalteparin and edoxaban, so it was non-inferior for the primary endpoint. Interestingly, if you looked at the individual endpoints, however, the secondary endpoints, you can see on here that there was an increased risk for a recurrent thrombosis in patients on the dalteparin arm compared to edoxaban, but what you ended up having was an increased risk of major bleeding in the bottom panel on the right with the edoxaban arm versus dalteparin. So it was interesting that the composite outcome showed non-inferiority. There are some differences, however, that you need to be aware of if you look at the individual components of that composite endpoint. And the conclusion that the authors drew was that oral edoxaban was non-inferior to subcutaneous dalteparin with respect to that composite outcome, but you might want to use caution in patients who you're worried about are at higher risk for bleeding. Now, shortly after this trial appeared, the SELECT-D trial appeared with rivaroxaban, and then the ATOM-BTE and Caravaggio trials appeared with apixaban. And once these 4 trials appeared, Caravaggio just earlier last year, then all of a sudden, there were a total of 7 systematic reviews and meta-analyses that appeared. So there was almost a feverish rush to get this out there. And these all differed a little bit in their design. They all differed a little bit in the number of patients analyzed, but all of them showed similarly that VTE recurrence was decreased with the direct oral anticoagulant compared to the low molecular weight heparin as the control. Major bleeding was slightly increased in all of them, although it was not statistically significant. Clinically relevant non-major bleeding was also increased and was significant in a subset of the analyses. All of these ended up suggesting that in patients with cancer-associated VTE, the direct oral anticoagulants are a reasonable alternative or different option that you could use. And really, most of the guidelines have now moved towards recommending the direct oral anticoagulants up front as the recommended treatment for patients with cancer-associated venous thromboembolism over low molecular weight heparins. Now, what other uses are people looking at for patients with thrombotic events? And here, there's also a very strong interest in identifying whether or not the direct oral anticoagulants might provide some additional benefit in patients with arterial thromboembolic events. Mostly for the longest time, antiplatelet agents have been primarily the agent used in patients with arterial thromboembolic events, unless you think it was related to atrial fibrillation. But for peripheral arterial disease, it's usually been antiplatelet therapies. The COMPASS trial was a series of studies that have looked at the use of a low-dose direct oral anticoagulant combined with or in place of antiplatelet therapy in patients with a variety of arterial diseases. And this study that I'm going to talk about that appeared in Lancet in 2018, COMPASS, looked at patients with stable peripheral arterial disease or carotid disease. It was a multi-center, double-blind, randomized, placebo-controlled trial where patients had to have a history of peripheral arterial disease or carotid artery disease, or they could have coronary artery disease, but they had to have an ankle brachial, ABI, ankle brachial index of less than 0.9. So they had evidence of peripheral vascular disease as well. The primary outcome was cardiovascular death, MI, or stroke. There were a number of secondary outcomes, also including limb outcome. So whether or not people lost a limb or had to have revascularization on a limb. The trial design is shown here. For this particular study, there was a run-in period to ensure compliance with participation on the study, And then patients were randomized to aspirin, which was considered the standard of care daily, or rivaroxaban 5 milligrams twice a day, or rivaroxaban 2.5 milligrams twice a day with aspirin daily. So noting that not only were these doses lower than what we use for venous thromboembolism or arterial thromboembolism, but it was also a different dosing strategy, spreading it out to twice a day instead of once a day. What this study showed was that compared to aspirin, this is the cumulative incidence risk of that arterial thromboembolic event outcome, the combination of cardiovascular death, MI, or stroke. You can see here that aspirin alone actually had the highest likelihood of this composite outcome, and rivaroxaban plus aspirin, that 2.5 twice a day with aspirin, actually was lower, and this was statistically significant decrease. Rivaroxaban alone, the 5 milligram twice a day, also trended lower, but it was not statistically significant. But what if you looked at limb outcomes? Limb outcomes had the same direction, in that patients with aspirin alone had a higher incidence of that outcome compared to either of the rivaroxaban arms, both of which were statistically significant in this particular study. Again, with the rivaroxaban plus aspirin versus aspirin alone being better, suggesting that you can combine a low-dose direct oral anticoagulant with aspirin to get a better outcome. However, the trade-off is that there is an increased risk of major bleeding. And you can see here either the low-dose rivaroxaban plus aspirin or the rivaroxaban alone versus aspirin alone had an increased risk of major bleeding. This was not fatal bleeding. It was not intracranial hemorrhage, but what was statistically significantly different was other types of major bleeding, including surgical site bleeding requiring reoperation or bleeding leading to hospitalization. Their conclusion from all of this was that low-dose rivaroxaban taken twice a day plus aspirin once a day reduced major adverse cardiovascular and limb events compared to aspirin alone. Major bleeding was increased, but fatal or critical organ bleeding was not. So you could consider this in a patient who might have a low risk, or who would have a low risk of bleeding. The COMPASS investigators have also looked at other types of things, such as after myocardial infarction and other arterial types of thromboembolic events, and all of them have this combined increased risk of bleeding when you start looking at combining a DOAC with aspirin compared to aspirin alone. Now, what about cardiac valves? Okay, everyone here recalls the REALIGN study, which was the study that appeared a number of years ago now. It was a phase 2 dose validation study that compared dabigatran versus warfarin in patients with prosthetic aortic valves or mitral valves. And what they showed was that dabigatran was associated with an increased risk of having a thromboembolic event. So this is probability of no event. You're less likely to have no event with dabigatran. So you're more likely to have a thrombotic event, and you're more likely to have a bleeding event with dabigatran. So that pretty much removed the direct oral anticoagulants from comparison to warfarin for most patients with prosthetic valves. However, it leaves the question open of whether or not a DOAC might be of benefit in patients with bioprosthetic valves or some of the newer design valves. In particular, RIVER was a multi-center randomized non-inferiority design study. It was a probe design, meaning open label, but with blinded adjudication of outcomes, that looked at patients who had permanent paroxysmal or persistent AFib or flutter and a bioprosthetic mitral valve, okay, a tissue mitral valve, and who were going to receive anticoagulant therapy. And they were randomized to get either rivaroxaban at standard dosing or warfarin with a target INR of 2 to 3, with a primary outcome that was a composite of death, major cardiovascular events, or major bleeding at 12 months. And what RIVER showed is that there was actually a slightly decreased risk of that composite outcome for the rivaroxaban compared to warfarin, and it did meet statistical significance for non-inferiority with this combined outcome. So in conclusion, patients with AFib who have a bioprosthetic mitral valve, rivaroxaban was non-inferior to warfarin with respect to the mean time until primary outcome. So therefore, rivaroxaban could be used in this subset of patients. Now, what about a prosthetic, a truly prosthetic valve? Here, there is actually a study that's currently ongoing that I want to let you know about, because it will appear at some time soon, I hope, is the PROACT 10A trial. And this is a randomized multi-center open label study that's looking at patients with what's called the Onyx aortic heart valve, or an Onyx aortic valve prosthesis with a particular vascular graft. Now, the excuse me, the Onyx valve is shown here. This is a relatively new valve that's been studied in a number of indications and actually has been shown to be less thrombogenic than other valves. And it's being put in the aortic position, which is also a less thrombogenic location for a valve to be inserted. So therefore, what the investigators for this trial are doing are taking patients who have an Onyx aortic valve, not mitral valve, just the aortic valve. They've had it in place for greater than 3 months, 1,000 total individuals they're looking for. They're going to randomize them to either apixaban 5 twice a day or continued warfarin with an INR goal of 2 to 3 with a 2-year follow-up. The primary endpoint is going to be a composite of valve thrombosis and valve-related thromboembolism. And this trial is currently open. I think it's an important trial that we explore and investigate as far as utility of the DOACs in this particular population. Now, what about special populations? Well, a key one is the pediatric patient population. And here there have been a number of trials that have looked at the direct oral anticoagulants in pediatric patients. Einstein Jr. was one of the first ones. This was a multi-center study at 107 hospitals, 28 countries, targeting children less than 18 years of age, initially treated with unfractionated heparin, low molecular weight heparin or Fonda, and then randomized to rivaroxaban or standard anticoagulant therapy. Primary outcome was symptomatic recurrent VTE with a safety outcome of bleeding. As you can see on here, this is the primary data slide. For the primary efficacy outcome, there was no increased risk of recurrent thrombotic events, and in the safety events, there was no increase in major or clinically relevant non-major bleeding, leaving the conclusion that in children with acute VTE, treatment with rivaroxaban had a low recurrence risk, as well as no increase in bleeding compared to standard anticoagulants, indicating that it could be used in these patients. Similarly, what appeared earlier this year is the Diversity trial, which was another randomized controlled open label study. It was a phase 2b/3, enrolling patients less than 18. Initial treatment with a parenteral anticoagulant followed by randomization to dabigatran versus standard of care, which in most cases was vitamin K antagonists. Here, the primary composite outcome was proportion of children with complete thrombus resolution, as well as freedom from recurrent VTE and VTE-related death. And what they were able to show, freedom from recurrence is shown here, with dabigatran etexolate being better than the standard of care on this graph, trending towards improved outcome. And if you look at any bleeding, you can also see here that the dabigatran in red was comparable to the warfarin in blue, leaving the conclusion that dabigatran was non-inferior to standard of care in terms of efficacy, with similar PK-PD relationships as in adults, giving pediatric treaters another option as well. So dabigatran also has been used in peds patients. What about new uses? What about the DOACs in outpatients with COVID-19? And here I'm going to tell you just about 3 studies that are currently open and enrolling that we hope will find out if they can help prevent thrombotic events in the non-hospitalized cohort of patients with COVID-19. The first one is Active 4B. This is currently open. It's a multi-center trial that's looking at antithrombotic strategies in patients with COVID-19 who are not sick enough to be in the hospital. It is enrolling folks who basically have had COVID-19 diagnosed in 14 days, non-thrombocytopenic, not in renal failure, and randomizing these folks to placebo, aspirin, apixaban at a prophylactic dose, or apixaban at a therapeutic dose, following these folks for a composite endpoint of symptomatic VTE, arterial thromboembolic events, hospitalization for cardiovascular events, and all-cause mortality at 45 days. Another trial also looking at rivaroxaban is the Prevent HD. This one is also open and enrolling. It's randomizing folks to placebo versus rivaroxaban at a prophylactic dose for a total treatment period of 35 days and follow up at 35 days and 49 days. Again, looking for decreased outpatient thromboembolic events. The last one to mention is the Active 4C. This is a multi-center adaptive trial that's looking at extended thromboprophylaxis for 30 days following discharge. So the patient who's been in the hospital and is going home is going to get randomized to look at whether or not extended thromboprophylaxis should be used. This study is also looking for 18 years of age and older, COVID-19 positive, hospitalized for 48 hours or more. They don't have to have an anticoagulant of some kind, and they don't have an absolute contraindication, and they're getting randomized to either apixaban 2.5 twice a day or matching placebo. And this study is going to stratify based on whether or not somebody was in an ICU setting by using the WHO ordinal index score. We're also including people who are going to be on antiplatelet agents when they go home as well. And this study is looking at the composite endpoint of venous thromboembolism, arterial thromboembolism, and death at 30 days after randomization. Now, to close, are DOACs the answer for all situations? Well, we do have studies that have shown that they don't work for everything. I think that prosthetic cardiac valves, you have to be careful. Clearly, the Realign demonstrated that dabigatran was associated with increased events. Currently, with prosthetic cardiac valves, we need to use warfarin in these folks until we have a study. Triple positive antiphospholipid syndrome has been studied in a couple of studies and shown to also require warfarin over a direct oral anticoagulant. End-stage renal disease is an area that you need to use with caution, and one that I don't have on here that I think needs to be also explored is whether or not we could use any of the direct oral anticoagulants in the pregnant patient population. That is something that definitely needs to be studied, however, and currently we only have low molecular weight heparins for that group. So in conclusion, anticoagulant therapy is used in a wide variety of clinical settings and diverse patient populations and being explored in more and more settings. It offers innovative approaches, alternative strategies for many of these situations, including use of really low-dose DOACs, potentially combined with antiplatelet agents. I think that the future directions, we're going to see an expanding role for the use of these novel approaches, as well as introduction of combination strategies that might be very interesting and useful. Again, modifications of this low-dose DOAC and antiplatelet therapy, can we adjust the doses to decrease the bleeding risk? And on this side, I show my disclosures. The only one that really is relevant here is that I am the study chair for the Active 4C, the extended thromboprophylaxis trial that I talked about briefly, which is funded by the NIH. Otherwise, none of these are directly relevant to my talk today. And I thank you very much for your attention and happy to address any questions or thoughts that you might have.